We have Dr. Aronoff here, ready to review one of the latest questions. Dr. Aronoff, hi.
Hi, it's great to see everybody. I'm going to share my screen here, so let me know. Hopefully, you're seeing my slides.
Yes.
And I'm going to go over a question that was, I think, a bit tough, a challenging one. As the first slide says, this is a rapidly growing mycobacterial bloodstream infection. I'm going to get right into it, and I'll read the case first. This is a 27-year-old man with sickle cell disease who presented with his typical chest syndrome crisis, fever, chest pain, and leukocytosis. Cultures are drawn, and vancomycin and levofloxacin are started. Chest radiograph shows new bilateral infiltrates. A film 1 week earlier showed only chronic scarring. Sputum gram stain, acid fast stain, and culture show only normal flora. Labs show leukocytosis, hemolytic anemia, and mild liver function test abnormalities. Examination shows no localizing findings. A tunneled double lumen subclavian line in place for 4 months appears unremarkable. At 96 hours, one blood culture grows a non-branching, beaded gram-positive bacillus that is acid-fast positive. Three further cultures, one through each lumen and one peripheral, are all positive at 48 hours for the same organism. And the question was which organism is most likely, with choice A being Nocardia asteroides, which probably should have been Nocardia asteroides complex. Regardless, choice B was Mycobacterium mucogenicum. C was Rhodococcus equi, D Legionella mcdatii, and E Mycobacterium tuberculosis. And I will say that the majority of respondents answered A, Nocardia asteroides. But the correct answer, or the most correct answer, was Mycobacterium mucogenicum. Nocardia asteroides branches, keep in mind in this case it was a non-branching organism, and is only partially acid fast. And bacteremia is generally secondary from pulmonary or disseminated disease. And this patient did have evidence of pulmonary disease, so that may be why that was chosen by some. Mycobacterium mucogenicum is non-branching and it is fully acid fast, which aligns with the stem of the question. It's recovered from routine blood culture bottles and often from somebody who has a long-term dwelling tunneled line, like the patient in this case. Rhodococcus equi is a pleomorphic coccobacillus. It is weakly acid fast, but certainly not a beaded organism. It classically causes a cavitary pneumonia in people with impaired cell-mediated immunity. A typical case might have somebody with advanced HIV infection. Legionella mcdatii is weakly acid-fast in tissue, but is gram-negative and doesn't really grow in routine blood culture media, so that would rule this out as likely. Mycobacterium tuberculosis, we're all familiar with, grows very slowly and shouldn't flag a culture at 96 hours, let alone 48 hours. So some important cues here. Not a branching organism and fully acid fast. It's positive in routine blood cultures at 96 hours, and even some were positive at 48 hours. And there's a tunneled line present that's been there for at least 4 months, and every lumen is positive. So there actually is a small literature on the intersection of sickle cell disease and bacteremia with Mycobacterium mucogenicum. A report from 2012 demonstrated 4 adults with hemoglobin SS disease and long-standing ports. These were in for over a year in most cases, some 2 years, some 4 years, in one hematology clinic. And there were these cases of Mycobacterium mucogenicum bacteremia over a 2 month, pretty shallow window in 2008. Patients had fever with back, chest, or limb pain, clinically indistinguishable from a vaso-occlusive crisis. Genotyping showed that all of these isolates not only matched each other, but they matched a clinic tap water source related to a faucet aerator. All of the ports were removed. All 4 patients recovered. There was no recurrence, and patients were appropriately treated. And the investigators really, I think, did a lot of good investigating to show that this went from infected tap water, enrichment and dispersion with a faucet aerator. The aerosol was in the area of the hand washing sink, and unfortunately, the saline bags for flushing were prepared right in proximity to that sink and probably got contaminated. Um, so this was really more about a group of people with prolonged IV ports who got contaminated infusions put into their ports. It's not clear that sickle cell disease per se is a risk factor for Mycobacterium mucogenicum, but sickle cell patients may have ports that are in for a long time. What are the risk factors for rapid growing mycobacterial collapses like mucogenicum? Well, the IV catheter is usually part of the story. In the vast majority of these bacteremia episodes, there will be a central venous catheter, and the risk increases with immunosuppression, how long a catheter has been in, and whether someone has received prior antimicrobials. The classic host is immunocompromised. Probably 4 out of 5 people have an immunocompromising condition that is often a hematologic malignancy. Corticosteroid use is common. And unlike neutropenic patients that have their own set of risk factors for other infectious diseases, these rapid growers seem to be in patients with lymphopenia rather than neutropenia. Uh, there are infections that occur in people without malignancy, and the case that was presented here is one example. Other folks who may not have indwelling ports, but are chronic injection drug users, or folks that are using injection drugs through chronic access lines, may be at increased risk. The syndrome for rapid growing Mycobacterium bacteremia is usually one of having a central line. Fever and chills with exit site redness or drainage is often seen. In the case we presented, it was not, and it tends to be a little bit more occult than with a pyogenic bacterium like Staphylococcus. Interestingly, of the rapid growers that cause this scenario, mucogenicum has been reported the most commonly. So that's a tip off in terms of the answer choices for this particular stem. Endovascular extension to cardiac intravascular devices is important, and also endocarditis can occur. How do we get from a culture to a species? Well, rapid growers will generally grow in a blood culture, particularly if an isolator blood culture has been obtained. These are not infrequently beaded gram-positive rods. That is similar to nocardia, but they are not branching, different from nocardia. Acid-fast stain would cinch that it's fully acid-fast. On a plate, these will grow relatively quickly, which is what differentiates them from the slow-growing mycobacteria like tuberculosis. And then sequencing and susceptibility tests can tell us what the species is and what our best combinations for therapy are. I put together this slide to sort of compare the most common answer that people gave, which was nocardia, with the rapid growing mycobacteria. And I've already mentioned several of these features. Mycobacterium are beaded, gram-positive sometimes, but not branching. Nocardia would be beaded, gram-positive, and branching. While mycobacteria are fully acid-fast, nocardia is partially acid-fast. Nocardia generally are inhaled. Mycobacteria come from contaminating injections of a port. So it's really a primary catheter-related bacteremia, whereas the bacteremia in nocardia is secondary to a primary visceral source. The treatments are different, and that's important. And where this can embolize to or set up shop elsewhere can be different. Nocardia, we often worry about the brain, less so with these rapid growing mycobacteria. And that is it. If anyone wants to reach me, my email is my last name, Aronoff at iu.edu. And thanks for tuning in. And I hope this is helpful.
This was great. Thank you, Dr. Aronoff, for the detailed and informative review. Dr. David Aronoff is one of the co-directors of the Infectious Disease Board Review course, and he will definitely be at the live and virtual course, right?
Oh, well,
And
proud to be. Yes, thank you.
looking forward to seeing you, Dr. Aronoff.
Thank you. Me too.